Hey Refam, my name's Kate and welcome back to Keeping It Real, the podcast talking bodies, bodies, bodies. Today we're answering the age-old question, what's the difference between a lower body lift and an abdominoplasty or tummy tuck? Richard and Kim explain what's involved in each operation, what the recovery's like, and who the ideal candidates are for each surgery. This topic is a listener question, so it's proof that if you ask, we will answer. Send any questions or things you want us to discuss over to us on Instagram and give us 5 stars wherever you're listening to this episode. Welcome. So today we chose this one because somebody messaged asking about lower body lift versus abdominoplasty, and I think we've done a lot of just one, just the other, but also not in that recent a memory. So back to our roots.
Let's go.
What is the difference between a lower body lift and an abdominoplasty?
So an abdominoplasty is removing the excess skin and fat, mostly skin, from the front part of the body, usually from hip to hip, belly button to pubic area. And a lower body lift is that plus extending it all the way around the back. So it joins up and you end up with a scar that sits just above the pubic line all the way around the hips to the top of your bum, looping around.
What are the main reasons someone would choose one over the other?
It's not necessarily the patient choosing. It's more comes down to our assessment. So a body lift as opposed to an abdominoplasty also incorporates a thigh lift and a back lift. So the triggers for me are one of two things. One, if the skin excess on the front or the abdominal pannus extends to the sides, then if you don't go all the way around or extend onto the back at the very least, you're going to end up with some flank fullness, which sometimes people confuse with a dog ear. It's not really a dog ear. The other indicator would be if there is a lot of fullness in the back, not necessarily circumferential, but as a separate area, plus or minus some droopiness or ptosis of the buttock. And I think it's very important to treat that entire area, the whole trunk, as a whole unit, because what I've found over the years is if I do an abdominoplasty but don't treat the back and someone's got fullness there or loose skin, then there's a mismatch and people are out of proportion. So the tummies can be nice and flat, but then you've got a fullness in the lower back or droopiness of the buttock area. And then it causes problems with clothing and people feel uncomfortable.
That love handle kind of area that doesn't traditionally get treated with an abdominoplasty, even with if we do a little bit of liposuction if it's full, but if there's excess skin there, and I often say to my patients, like if you can grab the outside of your hip like a loose pair of tights and you can grab skin in your hand, then you probably need to go all the way around.
Yeah, I think it's interesting because you might have it in your head that it might be massive weight loss, and obviously that is more who typically will go for a lower body lift. But I don't think you'll see some photos and you're like, oh, surely that's going to be a tummy tuck. But then you look and you're like, oh, it actually did go the whole way around. So it's not necessarily about like overall size, I found, in just our options.
Yeah, totally agree with that. I think some of the patients who get the best results, not necessarily the massive weight loss patients, but patients who have reasonably good skin, but we've made a joint decision to do a body lift and just for those playing at home, just a couple of similar meaning words, which would be 360-degree tummy tuck or belt lipectomy. From our point of view, they're all pretty much the same operation. Patients who haven't necessarily had massive weight loss can do very, very well with a lower body lift.
Are they usually standalone procedures or are they often combined with other?
It depends on the patient and how much tissue and how long it's going to take, but they can certainly be combined with other procedures. For me, it would not uncommonly be a breast reduction or a breast lift at the same time, or sometimes a brachioplasty and a lower body lift. I personally don't do thigh reduction at the same time as a lower body lift because they're two operations are generally working a bit against each other.
Are there any requirements for one or the other, like BMI or anything?
No, same. So definitely under 30, preferably under 28. Remembering that the general guideline for a healthy weight is under 25. So we're not exactly saying down to what is considered normal, but definitely patients do better, have fewer complications the closer the BMI gets to to 25.
Can men benefit from these as well, or is it mainly women?
Absolutely, men can. The indication is different because don't have pregnancies, and that's where a lot of the women have the excess skin from and potentially more likely to be abdominoplasty candidates, whereas men generally are more the significant weight loss. But certainly I've done both procedures on men, just assessing and seeing where the skin is excess, which bits need to be removed.
The difference, one big difference I find with men is that love handle area that Kim was talking about in that lower back area is often very, very prominent for some reason in men. And I've tried different things over the years. I've tried liposuction, but it's quite deep fat. It goes right down onto the muscle wall. So sometimes liposuction alone doesn't remove it all. And that's often a problem area for men. So I generally actually cut that fat out directly. So I lift the skin up and then actually cut the fat off the flap all the way down onto the muscle wall to get that nice contour and shape in the lower back.
What's the recovery like for both of them? Are they similar kind of recovery processes?
I actually think generally it is, even though the patient has a longer time in theatre and we're turning them face down to do the back component at the start. But a 30-minute operation versus a 5-hour operation, the patient isn't necessarily really aware of how long it's taking, and the anaesthetic doctors that we work with are excellent at controlling their fluid input and their recovery afterwards. And so I really find that most of my patients' recovery is very, very similar between the two procedures. And usually it's the anterior part that's the tightest because you're repairing the muscles from side to side and the skin from top to bottom. So they're tight in two different ways and they're hunched over at the front whether they've had the back done or not. So that's the part that really slows them down a bit more, is a bit harder to get in and out of bed, dictates the position in their bed. And I think adding that back part on, really, I haven't really found that it's made a whole lot of impact in terms of it's not an area that becomes more painful and it doesn't slow them down in terms of mobilising. Pretty similar recovery.
Traditionally, we've always tended to keep body lift patients in for 3 nights and abdominoplasty patients in for 2 nights, but definitely doing more body lifts with a 2-night stay, same as a tummy tuck, abdominoplasty, which seems to be fine. I think the key with getting out of hospital is having a motivated patient as well as staff who are really focused on the discharge planning and getting patients up and about and confident walking around. But for sure, the rate limiting step is the tummy tuck part.
And the drains, probably equal number of both patients would go home with drains, and having a drain in is not a reason to stay in hospital an extra night.
Are patients happy on the most part to be going home at the 2 days after a lower body lift?
There's a split. If I can be perfectly honest, patients who are self-funding, generally very happy to go home on day 2. Patients who have insurance and the hospital stay is covered, it's much harder to get them to stay 2 days, and not uncommonly they want to stay for 4 nights. My personal view with hospitals, if I was a patient, is to get the hell out of there as soon as you can. Bad things happen in hospitals as much as we try to avoid it, but there's what's called nosocomial infection, which is an infection you acquire in a hospital, and there are different bugs that are in a hospital. Plus your bed at home is more comfortable, your shower where everything is. And generally by the 3rd day, patients are self-caring. And if it was me, I'd want to get home.
And a lot of it is a positive mindset, a massive part as well. People coming in and they're like, yeah, I'm really keen to get home as soon as possible. And they generally do. Patients that are calling the rooms the week before surgery going, I'm not sure 3 nights will be enough for me. Not uncommonly. They are harder to get going and motivated to leave hospital.
You said that the recovery seems to be pretty much the same for both. What does that look like in terms of days and weeks after the operations?
First couple of weeks are a little bit hectic. As Kim was saying, you are walking a bit like an old person, hunched forward. You can't stand up straight because the tummy is so tight. So that makes it difficult getting in and out of bed. 2 weeks is probably average. Some people will march in here at 1 week and you would swear they hadn't had surgery yet. But there are some people who it takes a little bit longer. Most people, I think, would be walking upright by 3 weeks. And then you go into the intermediate phase, which is 2 weeks to 6 weeks, where you'll start getting back to more normal activities. You should be able to start driving a car. If you're doing office work, you could get back to that. Heavy lifting, you may not be getting back doing that. We partner with a PT nearby our office, and she's got a range of exercises that patients can get into, usually by about 2 weeks, and we give all that information when you book your surgery and have your pre-surgery consult with our nurse. And then by 6 weeks, usually the garment is off, the taping all stops, and you can start getting back into everything normal and building back into normal exercise routines, running, gym, whatever you like. I think the big one that everyone always is worried about and thinks we need to wait is getting the wounds wet, either in a shower, bath or swimming. I'm yet to see a problem caused by a shower, swimming or a bath. Unless there's a problem, I'm usually pretty happy for patients to go in the shower straight away. On the table, we wash all the wounds down with salty water, so going in the ocean shouldn't cause too many problems. But definitely by the end of the first week, you should be able to go for a swim, and particularly people having surgery around the summertime, that can be one reason they like to delay it, because they might be around pools and going in the water and it's hot. And as long as you're not going crazy, you get out, you dab the wounds dry, you won't cause any problems.
Just thinking about someone who's hunched over and a thing, they're just like crawling to the
Well,
pool.
yeah.
And they're like, let me
Walking down the beach probably less fun. And then probably the only thing beyond that sort of 6 weeks, and is very variable between patients, is the amount of swelling that you've got. And so sometimes not just getting rid of the garments, but wearing them for exercise, or at the end of the day if you're a bit puffy and swollen. And there's a real spectrum. Some patients 6 weeks, zero swelling, some at 6 months still end of the day puffing up a little bit. And that just it just takes time to settle. It's not a complication or a problem, it's just a bit annoying, something to get used to.
Speaking of complications, what are they typically? What are the common ones for both lower body lifts and abdominoplasties?
I think complications for both actually relatively similar. We break it down into related to the surgery, the anaesthetic, and then early, middle and late. So it's a full anaesthetic. The commonest probably anaesthetic thing would be having a little bit of a sore throat afterwards, sometimes some nausea, obviously discomfort and pain, which is addressed in hospital, and making sure that you're all totally comfortable and not feeling sick before you go home. Surgical type of things, very uncommon to have any complication on the actual operating table. And then once patients are home, in that short to medium term, wound infection, again, very, very uncommon. Sutures spitting, so we'd have lots and lots of dissolvable sutures under the skin. It's not uncommon for some of those little knots to come to the surface. Not really a complication, just a minor irritation, things that we can deal with here in the rooms. And then in this sort of longer term, pretty uncommon, most of these things are all uncommon, but some asymmetry. Most people's bodies are asymmetrical to start with, so not the rarest thing to have not a perfectly straight line scar. Richard mentioned dog ears before, can have some little bits of excess skin at the end of a scar. If the scar goes all the way around, then it's pretty uncommon with a lower body lift to have that, or dissatisfaction with the results. And I think for me, more commonly, that would be the patients that have absolutely terrible quality skin, like the 50 plus kilo weight loss. And no matter how tight you get their skin on the day of surgery, because their skin quality is so poor that by the 3-month mark it will have some laxity, and you could do the operation again 6 months later and they're still going to get some looseness of the skin just because of their starting point, I think.
And the only thing I'd add is just further to what Kim was just saying about the residual skin laxity. I tell pretty much all patients when they're leaning forward, there will still be loose skin, because no matter what the reason for this operation, at some point your skin has been stretched, and so you've got less elasticity in that skin. So when you're leaning forward, if you're doing a plank, there's always the potential there's still going to be some loose skin. That's not a complication. It's not a reason for a revision. That's just the quality of the skin. And as Kim says, we've pulled it as tightly as we can. And you need to have a little bit of loose skin so you can stand up straight if you don't have the elasticity.
Same with the sitting down. Like when people come in and be like, they're sitting and they're like, oh, I've still got some loose skin here. It's like as soon as they stand up, it's washboard. And it's like it's impossible to have no skin when you're sitting down.
Yeah, it's like you do want that. You want to be able to have a
otherwise
functional body. You want to sit, you want to stand, you want to jump, you want to skip, like all of those things.
Otherwise you'd be bent in half for the rest of your life.
Yeah. It's just like, I know because Richard's come in and talked about it before. If you're only looking at photos of people or whatever on social media, like in this very posed thing, then you're so focused on what your body looks like afterwards that you're like, well, that doesn't look like that. I promise that anybody sitting at a table, sitting down at a chair has rolls.
And if you have to twist and move and contort your body into a weird position to be like, see, this is when the skin changes.
So just related to that, we've just recently had a couple of inquiries about reverse abdominoplasty. The theory behind that is you cut skin out from the upper part of the abdomen and put the scar into the inframammary fold. I'm generally not a huge fan of that. Many years ago, I did do quite a few of them, and I tried all sorts of techniques of anchoring that upper scar so it doesn't descend, but generally gravity will win. And what ends up happening is the base of your breast that we try so hard to preserve with an internal bra descends down, and two things happen. You end up with the loose skin back in that upper abdomen, and your breast, the bottom of your breast gets pulled down, so your chest looks longer and your torso looks shorter, and there's some of the dimensions and proportions that we're trying to reverse in many of these procedures. So there might be a small cohort of patients who that might be suitable for, but generally the results are pretty unsatisfactory in my view.
Such a weird thing to request.
Yeah. No, we've had two patients, I'd say, in the last month.
Really?
Yeah. Generally they do very well with just a standard abdominoplasty. I think they think the skin is just in the upper abdomen, but the problem is the belly button is holding everything up above it. And what you got to understand with a tummy tuck or a body lift, we're cutting around the belly button, so transposing that and then pulling all of that skin. We raise that skin all the way up to the chest margin, almost up to that inframammary fold of the breast, and it all gets pulled down and redistributed. So we're not addressing it, but you're much better pulling it down with gravity than trying to hoik it up and somehow get it to stay. I've tried stitching it to the ribs. I've tried stitching it to muscle. I've tried putting mesh in and then stitching the mesh onto the chest wall and then stitching the flap onto the mesh. And they all just recurred or pulled down on the breast. And
I'd like to take back what I said about being a weird request. That makes sense that they, with having the loose skin up top, to think that that's like, oh, but my bottom's fine. I want to do this way.
I think I've actually done one in the last year, and that was someone that had a lower body lift and had a bit of loose skin there. But the indications are very, as you said, very, very small. While we're on that, I think it would be interesting to talk about a corset abdominoplasty. And that is what some of our colleagues would do instead of doing a lower body lift. And what that is, they're often doing breast surgery with it at the same time. And they are essentially making a cut in that inframammary fold, so at the top of the abdomen, at the lower part of the abdomen, like a abdominoplasty, but then also a vertical one that joins up the two. So it's almost like a sideways H or a giant I. When they examine the patient, they pull the skin forwards. And there's a whole lot of skin there, then that's the way they're addressing it. Whereas our approach is because the wider part of their body, you are still narrowing them because of the waist is smaller than the hip. That vertical skin out without adding that anterior vertical scar, which is usually pretty unsightly. Kind of
so
similar, but
interesting.
different.
See, because when you said corset, I was like, oh, because you guys stitch
It's
the
like
abs together like a corset. So
Yeah,
I was like,
no,
we
this
don't
is
do
the
that,
s-
but
we
on
do
the
that
outside,
on the outside,
outside
yeah.
corset.
So that, they have a scar that goes vertically
rough.
around the belly button.
I've never seen the like flipping of the body into prone. How do you guys do that in theatre?
well, Personally, I don't.
You don't help.
I might if I'm asked, if
Giving
there's shorthand.
directions.
I've got to protect these things. These are very valuable. So it's pretty straightforward. We bring another bed in. Patient gets slid across onto the other bed, all still under anaesthetic, and then flip back, like flipping a burger, flip back onto the operating table. Slide and flip.
Roll.
I
Just for
used
those,
to love that
for
dance.
for those watching on YouTube, and if you are listening, go over to YouTube and have a look. Slide, flip. That's it.
But carefully, lots of hands, not Rich's hands, obviously, but lots of hands on it. The anaesthetist is in charge because they're in charge of the airway and the neck, keeping the whole spine in alignment. And the patient, when they're face down, there's a special foam pillow because they've got a breathing tube coming out their mouth, so they can't be face smushed onto a normal pillow or anything. So it's a special designed pillow.
Like a massage?
It's like foam. I was just going to say that, kind of like a massage one, but I reckon this looks more comfortable. Maybe they should use that. And then it's got a hole on the side of it where the breathing tube can come out without that getting squished as well. And then we either put a whole lot of pillows underneath the patient, or there's special pillows that are just foam around the outside so that their chest and their abdomen can move in and out when they're breathing.
As Kim is saying, it is actually a very serious part of the operation. So I'm observing.
The coffee in his hand.
But a couple of things to note. So I'll always put the catheter in after we flip because it's just one less thing that can get caught up. So backlift usually takes 1 to 2 hours. So patients are fine without having a catheter in for that period. So we'll do that after. And the other thing, just to think about it, when we're flipping, we have to put the post-op garments underneath the patient. So you've got to line them up so that when the patient flips, they're in the right spot as well.
Oh.
So that is something that you really need to pay attention to, because once they're flipped, if the corset or the bra is not lined up, then you've got to move the whole patient, and that becomes a little bit harder.
Yeah, right. And you always
do the back first.
Yeah. Okay.
Yeah, and we generally always have the garments on the operating table, so it just makes it so much easier at the end of the case when the patient's then, if they're being jackknifed for an abdominoplasty or lower body lift and their bed's in a specific position, that the garments are just there to pull them around and do them up. Not many other surgeons apparently do that. I always get comments in theatre saying, wow, you guys are it's so clever that you do that, because
Do what?
put garments on the bed. There's some people that they get them to put them on in recovery. The patient's like semi-awake and combative. And
what can I say?
Why do you always do the back first?
Because the back, when we cut the skin out from the back, the patient is basically flat. But when we're doing the tummy, we bend the patient so we get the maximum amount of skin out from there. And then the patient stays in that beach chair position as they go round to recovery and back up to the ward. So if you would do the tummy first, it would be hard to maintain that position when you reposition them prone, lying on their tummy.
Yeah, because you'd have to like flip them again.
And then they'd be bent.
Otherwise they'd wake up and be like, ah!
And they'd be more likely to pull it apart.
Yes.
Yeah. Wow, it was time that we redid this because I knew you always did one side first, but I can't remember which. What about muscle repair? Is that in both operations?
So muscle repair is standard really for both, certainly in all women. I would very rarely not do a muscle repair in a female patient, regardless of whether it was pregnancy or weight loss. Men, I'm a little bit more conservative because generally men don't want to come in at the waist. So we're trying to achieve a body shape that is more of a rectangle rather than curvy. The muscle repair or the tightening of the tummy wall, which is probably a better way of thinking about it, that's what that can do. And so it'd be a bit feminizing to do that in a male patient. So there's still some indications occasionally we'll do it.
Interestingly, I had a new patient consult today and she's come in to talk about abdomen and breasts. And the very first thing she said to me is, I'm keen to get my lower tummy removed. I don't want a muscle repair. And I was just like, explain why. And she'd helped her daughter through that same operation a year ago. And she was like, she was so hunched over and she was really uncomfortable for weeks. And I was like, yeah, that's not purely about the muscle repair. So how about let's have a chat? I can talk you through the pros and cons. And yeah, I'm sure she would absolutely benefit from a muscle repair. And yeah, it's going to be a little bit more uncomfortable in that first week, but the ultimate outcome is going to be improved. Yeah. And the hunched over and the tightness is, as we've talked about, largely from the skin removal, not from the muscle repair. So
you're going to be out of action for 2 weeks anyway. So final question.
Whoa, supplementary.
Yeah. What advice do you have for somebody who isn't sure about which surgery they're interested in?
Have a consultation and we'll be able to guide you for sure. You don't have to make a decision before you come in. If you know what parts of your body concern you, you don't have to know the answers. That's what we're here for.
But if you do go and have a consult and it's for your tummy, and we're not saying you have to come and see us, but if someone doesn't look at your back, I think it's a bit of a red flag. I think you need to at least consider that whole area, because certainly early on in my career, you do a great tummy tuck and then patients would be concerned about their lower back. Just there may not be anything to be done, but I think it's important to look. You can at least address it or discuss addressing it in the one surgery rather than having to come back and have it done at another operation.
If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.